So we're next going to talk about some of the eye movement abnormalities and the pupillary response that you can see. And the reason why I'm going over these specifically first is because I saw a lot of confusion on the survey we sent out about these in coma. So we're going to talk through these, then we'll go to coma, and hopefully that will make coma make a lot more sense. So Greg already talked about the different cranial nerves that are involved in eye movements, and you guys all know this, but I figured that we'd start with the things that you already know, that you have cranial nerve 3, 4, and 6, and they're all midline in the brainstem. And you guys know that the trochlear nerve controls the superior oblique. The reason why it's called the trochlear nerve is because trochlea means pulley in Latin, and it looks like a pulley. And the abducens nerve abducts, and that's why it's called the abducens nerve. Oculomotor controls everything else. So what I'm going to focus in on is the control of horizontal saccades, because that's particularly important when understanding coma and herniation localizations. So it's important to know how we go about producing horizontal saccades, given that it involves multiple parts of the brainstem. The big concept is that when you move your eyes laterally through a saccade, then the eye going laterally drags along the eye that ends up going medially to follow. So you start with the frontal eye fields. There's lots of different parts of the brain that are involved in eye movements. There's lots of different systems involved, and you guys probably remember some of that, probably not that much. I don't remember that much from the first year neuroscience course. It's complicated, but you can simplify it down to this, that the frontal eye field in the frontal lobes, that's why it's called the frontal eye field, sends a signal down through the brainstem, it decussates, and goes to the perimedian pontine reticular formation. Where is that in the brainstem? It's in the pons. That's why it's called the pontine reticular formation. A lot of these things actually have their locations in the name, and I didn't realize that was the second year. I realize that now. They give you lots of clues. So it sends it all the way down to the contralateral side, and the PPRF is then involved in coordinating that signal to then initiate the actual eye movements, the eye saccade, in the opposite direction of the frontal eye field that signaled it. So it sends a signal up to the 6th cranial nerve nucleus, the abducens nucleus, right above it in the midline of the pons, the lower pons, right here. So it's going to the ipsilateral side, contralateral from the frontal eye field involved. And from there, the abducens nucleus does its thing. It sends a signal to the lateral rectus contracts, and you have your eye AB duct out. However, at the same time, the abducens nucleus also sends a signal through the MLF, the medial longitudinal fasciculus. It has medial in the name, it's medial, it runs through the brainstem, it goes up. It's going up to the 3rd cranial nucleus, which is also medial in the brainstem and is in the midbrain. So it goes up there, it synapses on the cranial nerve 3 nucleus, the oculomotor nucleus, and the oculomotor nucleus is like, oh shoot, the other eye is going out to the lateral side. I need to go medial so we have conjugate gaze. So this happens all at the same time to make sure that this eye is looking to the left and this eye is looking to the left at the same time. Okay, so it's actually pretty simple when you break it down like that. Where it gets complicated is when you think about when you have lesions, what do you see on exam? So these are my nice little eyeball diagrams. They kind of look like olives. Sorry about that. So this is for when you have a lesion to the left PPRF. So what happens when you do that and you attempt to have a saccade to the right? Well, the frontal eye fields send a signal down. It gets down to the right side of the PPRF, and it's fine. It ends up signaling just fine. But if you try to attempt to gaze to the left, then it can't initiate it because there's no way for it to get to the PPRF and have it initiate all these movements that we talked about earlier. Now, if you have a lesion just to the left abducens nucleus, if for some reason you had a lesion just there instead of the PPRF, you'd see the same thing because it's necessary for coordinating the signal to both the lateral rectus and the medial rectus on the other side. So how about lesions specifically to the abducens nerve? So this is different than the abducens nucleus. And the reason why is because the abducens nucleus is still working here to be able to send a message through the MLF to the contralateral oculomotor nucleus. But there's no way for the lateral rectus to be able to move left. So you see the eye that's trying to move medially be able to move medially, but the eye trying to move laterally and abduct isn't able to do that. So now we're going to talk about the right MLF, and the reason why I'm doing the right is so we keep everything consistent with the same pathway, but just note that we're switching to the opposite side of the brainstem now. So when you have a lesion to the right MLF, then you're able to have this abduction of your eye, but the eye that's being dragged along through the MLF isn't getting that signal, so it's not going along for the ride. And this is confusing to the eyes, and they don't like it, so there's nystagmus. All right, so that covers the saccades that happen horizontally, which is important for understanding coma and herniation at different parts. So we'll next talk about pupillary light response and the pathways involved in that. The big takeaway here is that it's through the midbrain. These processes are happening to make the pupil constrict in response to light. That happens in the midbrain specifically, and that ends up being driving what you see with different herniations and causes of coma. So just running through the pathway of how this occurs. So you end up having, of course, light hitting the retina. It starts there to be able to respond to it. It can happen just in one eye unilaterally, but as we'll see, it'll end up involving both eyes at the same time, but starting just with one eye. It travels through the optic nerve. Before it gets to the LGN, it branches off and goes into the midbrain. So once it's in the midbrain, it synapses on the pretectal nucleus that's in the dorsum of the midbrain. And from there, the pretectal nucleus sends it to the bilateral Edinger-Westphal nucleus. You guys probably remember that from anatomy last year. So Edinger-Westphal nucleus, it's just a subnucleus of cranial nerve 3. It's got a fancy name, but in terms of like understanding where it is, it's just part of cranial nerve 3, the nucleus. So from there, the parasympathetic fibers, because this is happening to actually mediate pupillary constriction through parasympathetic fibers, it's traveling out along the outside of cranial nerve 3. So the peripheral aspect of that cranial nerve is where these are traveling. And you guys probably remember that there's things involving the ciliary ganglion. It's not super important here because that gets a little bit more into anatomy than into neurology. But basically, they end up going and the parasympathetics constrict the pupil response to light. It ends up happening in both eyes at once because the pretectal nucleus sends signals to both Edinger-Westphal nuclei.